So I just wanted to talk a little bit about some unconventional, quote-unquote, methods of doing surveys, especially in situations like Syrian refugees somewhere in Greece or displaced Ukrainian people. So situation where we have a middle-income country, really, and in many cases it's a post-socialist system country with the kind of former socialist system healthcare, and where nutrition programs are different, where wasting is basically either very low or non-existent, and then often people who are working in emergency nutrition get a little bit lost because our knee-jerk instinct is wasting, and if there is no wasting, then people are not so sure what they should be doing, and the second, obviously, knee-jerk instinct is always IYCF. But it's also a challenge because, as we know, the nutrition cluster is coordinated habitually by UNICEF, and UNICEF's mandate is mothers, women, and young children. And so, for example, when the most vulnerable nutritionally group is, for example, elderly, because they lose social support networks, younger people migrate and they cannot, or they are unwilling to leave their apartments to be looted with all their left meager possessions. And sometimes they also have mobility problems to even go out and get some bread and get some food, to that degree. And there is no volunteer networks to help them. So in those situations, we have to think about different kinds of studies and go out of our comfort zone and exercise a little bit of common sense. So I will talk a little bit about my experiences when I was volunteering to coordinate for UNICEF nutrition cluster in Ukraine, and we did 3 unconventional fun surveys. One was the IYCF survey among displaced women, so not women in the conflict zone, but those who were displaced. IYCF survey. Second survey was a random representative survey of older people over 60 years old around the conflict zone, not just displaced, but people who were resident. And the third survey was also a survey of pregnant women, also resident pregnant women around the conflict zone, but a survey of the pregnant women which included anemia. And anemia measurement was also a little bit unconventional. So I will go one by one and just stop by a little bit on the methods, how we have to modify the conventional cluster survey methods that we usually do, like mixed or DHS or SMART, kind of, whatever. They're basically the same, how we modify them in those situations where the populations are very difficult to find and they constitute a very small percentage of the population. So random selection of the households doesn't work, and it's very difficult to find the list of the beneficiaries who you are targeting, like women with children under 2 or pregnant women, etc. So the first survey was in displaced women with children under 2. First of all, the problem was that displaced women in general constituted a relatively small percentage of women in that area. So they kind of already were difficult to find. And obviously displaced woman with the child under 2 is much more difficult to find than just a displaced woman. So a random selection of households and going household to household will not work because it will take ages and you will not find sufficient sample size. So you have to find some lists of these women registered somehow by someone and see if those lists, how can you make them most updated, most representative, least biased to do your study. And the problem was that, yes, some of these women, especially women with younger children, if there are humanitarian assistance, NGOs working, Red Cross, etc., they can be registered with them. They also normally register with the government because the government had social safety network payments for displaced. But the government, we had to discard from the beginning because they were not sharing individual data with any organizations. So we had to go by asking our UNICEF and NGO colleagues to work with whatever organizations had those lists, find those organizations. In this case, the only list that is usable is the list that either have a phone number, so you can call and ask what the address is, or that has the address. And most of the lists, they did have phone numbers, and phone numbers generally were more reliable than the addresses, and often people were more reluctant to give the address, but less reluctant to give the phone number. So we got the phone numbers from several different organizations. We reconciled them for duplicates using the names and the phone numbers, and then after we did the duplicates, then we randomized the list, selected kind of the random number of the sample that we needed. But the difficulty also in these kinds of studies is that you are faced with uncertain but potentially very high non-response. One, because the phone may simply not be working, and we had about 30%, 25% of those. Second, the phone may be working, but those people moved to another region, to another area, so they're not in the area that you are surveying anymore. And three, even if you get through to the phone to them and you can talk to them, they refuse because they're afraid to meet with you. They're not so sure about meeting some strangers, letting strangers in their home, etc. Because of all different reasons, including more political reasons and also it's just more common crime reasons. So in that situation, what we do is we randomly select 50, 60, 70% more than we need for our sample, and then before going and surveying these women, we call them one by one by one by one, and before discarding we call them at least 3 times during 2 consecutive days. If we cannot get to them, then they're discarded. If they've moved, obviously they're not included, and if they refuse, they're not included. But then basically we do it as a quota sample until we get our 400 to 600 women that we get. It's just the phone list, it's just the homework, where before we start the field work, all the interviewers and some more, they just sit on the phone and work out the phones and write down the names, write down the addresses, and also make appointments, because when you call people in advance, first of all, you have reasonable assurance that they will consent to the survey, and second, you can make an appointment so that it's less likely that they will not be home, because especially in the urban areas, we have lots of non-response, which is due to absenteeism, because people just go out to buy food or whatever, run errands or stand in lines for humanitarian assistance. So that was one survey. The second survey was, as I said, representative population survey of older people and over 60 years of age. And here we did anthropometry, we did arm demispan, we did weight, we did MUAC, we did food security, so we asked all these scales of dietary diversity and food frequency. And we also did some other scales because we could not really find any representative prevalence information, for example, for chronic diseases. So we asked them about whether they have a chronic disease. We also administered mental health scales because, unfortunately, in the former Soviet countries, mental health is really, really underdiagnosed and has a horrible stigma of people being crazy. So people, there is no modern psychiatric drugs really available and no network of psychological help, unfortunately. And especially with older people who are disabled, who lose their social networks, this can be a very severe issue leading to severe forms of depression, anxiety, suicide, PTSD. And we also measured the disability scale to see what percentage are disabled, have difficulty moving, have difficulty feeding, dressing, washing themselves, and what kind of help they have available. So in this case, we went with the classical cluster survey. We had population data, of course, was relatively reliable. There was not so much displacement at that time because it was 1.5 years after active conflict was finished, and it was kind of just simmering a little bit. So we had population data from what they call the electoral precincts. So admin data was available with specifying the boundaries of each area and the approximate number of households and what streets were included in each segment. So we selected clusters in the classical way, but then obviously we were not able to spend so much time as DHS or mixed surveys do to send the teams in advance to enumerate all the houses in the segment and randomly select them before sending the teams to collect the data. So we just did select several random points. So each cluster had 3 different random points selected, and the teams or the interviewers went into those 3 random selected points and then went with the scheme that we devised, kind of every second or every third house or flat, to knock on the door and to see if older people were present in the house, then they administered the survey. Here, obviously, older people were in much higher percentage of households than women who were displaced with children under 2. They were much common. About 40 to 50% households had older people, so it was not such a burden to knock on the door of these randomly selected households. The problem was more that half of the doors approximately did not answer, so they were knocking and nobody was home, so we did not know actually how many older people we lost that way. And also in some cases we had refusals because people were just reluctant of letting strangers in and spending time with them in the house because of all these issues that we mentioned. So in this case we also were not sure on the non-response rate, both because of not answering the doors and because of refusals. So we gave the teams also quotas, basically. They would go and knock on the door in a systematic random selection way until they get 15 or whatever number of subjects they had for the cluster to fulfill their quota. And the third survey was probably the most interesting and least conventional. We did survey of pregnant women, resident pregnant women around the conflict zone. The challenge with this again is that pregnant women are very small percentage of the population, especially in the populations that have low birth rate. And so doing it in the conventional way, you need to go to probably 15-20 households before you find one pregnant woman, whereas with older people you have to go to 2 households to find one. So we decided to sample them through the prenatal clinics. Why? Because the prenatal services coverage in Ukraine is very high. In the socialist system, they have to go and register as early in pregnancy as they can, and then they go for checkups every 1-2 months, and they also get routinely, basically compulsory analysis of hemoglobin at least twice to 3 times in pregnancy. So our main goal here was first to estimate the prevalence of anemia, to estimate the access to health services, and also the prevalence of availability of the prenatal training for mothers on IYCF and infant feeding, especially for new first mothers. And 3, also to look at their access to humanitarian assistance. And here, what we decided, as I said, to sample them through prenatal clinics. We got exhaustive lists of all functioning prenatal clinics in the conflict area. We randomly selected the ones population proportion not to size, so that we got the clinics with the most visitation, and then we just randomly selected the days, and whatever women showed up for prenatal checkup on the randomly selected day, the interviewers were in the clinic and they were surveying all women who showed up in them. So clinics were randomly selected, and then the day was randomly selected that way. We decided that we will achieve randomization more or less suitable to defend this as a semi-representative sample. And since it was not feasible to do hemocuse, all we did was ask women, when was your last hemoglobin test and what was the result? And since it was right there in the clinic, they could check with the doctor and they could give us exactly the last hemoglobin test result. So even if you're doing anemia survey, you don't always have to measure anemia. You can just ask people about what was the latest result and you can use it. And what was important, because these, like the clinic administration and the staff, they would not have accepted the interviewers unless we contacted first the regional health authorities, and we told them which clinics will be selected, on which days the interviewers will be there, so they gave them a call. They told them that these are legitimate people, they will have letters from UNICEF, and we approved them, so usually it was very, very cordial and hospitable. They were given tea, they were given empty offices, to conduct interviews. Women were encouraged to participate in the interviews, and all the information was available. So I'll stop here because I'm taking probably too much time, but just to share some of the interesting ways that you can do studies creatively in the situations that are not just wasting.
Thank you all. One question from the moderator. I'll take the moderator's prerogative, and then we'll open it up to questions from the audience. And my question is more general. So you guys did a nice job explaining how the studies had to change in response to Ebola in Sierra Leone, in response to the natural disasters in Nepal, and in response to the movement in Ukraine. Thinking back on the design at the inception of the research, how would you have changed it if you had known that these incidents were going to happen? In terms of maybe the number of people you enrolled, the way that you enrolled people, maybe the duration of the study, maybe in terms of your methods of follow-up, anything in terms of the protocol that you would have changed knowing what you know now in terms of the humanitarian situation?
Yeah, thank you. I think it's the most appropriate question for this kind of research. Ideally, with an RCT study design, there is no remote control management of the project. All OTP services deliver the same services homogeneously, and this was not the case for us as well. And the data collection is supposed to be accurate and well managed. Since we are conducting this kind of project in real life, we have also to estimate the level of the political influence on the service delivery. The fact that, of course, the staff receive low salary and there is a weak monitoring of the nutritional treatment outcomes. Therefore, probably the main question would be, shall we conduct a randomized control trial knowing all those criteria? Probably not. We see that the results that we expected are not responding to the level of expectation, even though we surprisingly see other outcomes that we did not expect. But regarding the study design, that was your question, conducting RCT, which is already a very difficult study design to implement in the, let's say, normal context, it becomes very challenging in context where a crisis occurs. So probably we should have revised or had a plan B for designing this study.
Thank you. As I said in my presentation, we only set out to look at vitamin A coverage at the beginning of our exercise. And had we known that the funding would have increased as it did twice and the study period extended twice, we would have set up a sample size which would have been able to show the differences between growth in the 3 study groups, the groups that just had vitamin A at 6 months, those that also had participation in timely introduction of complementary foods, and the group that opted for family planning. The early stats looked as if they was going to show that the children whose mums had opted for family planning were growing better than those who hadn't had that opportunity. But as I said, the sample sizes at the beginning were not set up to make that. And we had lost too many kids to follow up because of the mobility of our communities. I don't think we lost many kids because of the mortality issues. I think they just had moved. Sierra Leone, as Ebola demonstrated, is now a highly mobile society, and people come down from the provinces to deliver in the capital, and then they go back up to the provinces. Just like with Ebola, when Ebola comes to one village, they up and they off, and you can never catch the Ebola because they've always moved ahead of you. So we would have had a much bigger sample size, but we would have, I think in retrospect, we would have liked to have known more realistically our funding base and the time frame that we had available for the study.
I think the problems that people run in these situations of the surveys when they predetermine how many households they will need to find this many women or this many children is when they get unexpectedly high and highly uncertain or variable non-response rates. And when you are getting only 40% of your sample that you expected to get after 2 or 3 days, you are starting to panic because you don't know what to do. Well, basically, if one-fifth of your survey is already finished, and you got only 50% of the kids that you expected to get, and if you go that way, then basically your survey will be a failure. You spent all this money for nothing because you achieved only 40% of your sample size. So what are some of these things to anticipate? So first of all, we need to be very cognizant that there may be things like that, and to really be careful and try to anticipate them from the beginning. One reason for non-response is obviously absenteeism. So we need to understand when are the market days, when are like the field work and people are likely to be out, and also especially absenteeism is more a problem in urban areas where people are likely to go out and nobody is home during the day. Second big problem is when they refuse. Normally we are very lucky because all the people in the field in those low-income developing countries are very nice and very, very few refuse. But in the countries like Ukraine, for example, we were faced with very, very high refusal rate, like 40% refusal rate, notwithstanding that we were actually offering small monetary incentives. So, and the third, obviously, is rapid recent movement, because I will just talk in a minute about this case in Rohingya refugees survey, where we literally asked UNHCR staff to enumerate new arrivals in the old registered camp 3 or 4 days ago, and after 3 or 4 days, we sent interviewers to find these randomly selected people from the list that they compiled, and half of those people were gone, and we were not achieving that. So all these things can be mitigated. One, I always say, if you expect this, do a little bit more of your homework, do a little bit more of the pre-test. If you have a phone list, just call 50, 100 people and see how many don't answer the phone and how many are moved and how many will refuse. And that way you will know what approximately non-response rate you will be expecting. If you feel uncertainties and you don't sample from the phone list, you're sampling from the field, just send people around and see what percentage of the flights will not answer the door and what percentage of people will refuse in those flights, etc. So getting a pre-test, because usually we say pre-test is for us to observe how long the interview takes and whether they know how to select the houses and how well they conduct the interview, but in this case you can actually a little bit extend the pre-test and use it also to estimate human response rate.
Fascinating to hear about the survey of the elderly. We don't hear about that very much. Just wondered if you'll tell us briefly about the results and how they were used. And secondly, presentation on the call, I have to ask is, what did you find out about the reason why mothers were less depressed if men weren't around? Not just the fact of it, but why?
And then one more question and we'll field them.
Yeah, I mean, this is again a question from Oleg. I mean, I really love the way you're presenting all these different kind of challenges. Because to a large degree, doing a survey is a little bit like problem solving. You're constantly trying to work out what to do, how to do it. But my question to you now is like, every time we do any of this like solving of a problem, it doesn't matter how much diligent we are, we're always going to be introducing some non-bias. My question is, when did you draw a line? Is there a moment that you need to draw a line to say, this method is not any longer the method that needs to be followed?
Yeah, I have lots of questions, but I'll start. Is a single parent family not vulnerable? We keep hearing that single parent families are vulnerable, but you've shown that if the dad's there, they're more vulnerable. But why are we selecting single parent families for intervention is one thing. Benny Turan did a study years ago, which he couldn't get published, which showed that exercise of children, just taking them for a walk 100 meters there and back, increased their growth and increased their rates of weight gain and so on. And the question then is, to what extent does increased exercise from your interventions account for your results? The third question is, if you can't get decent data, is it worthwhile doing the survey in the first place? Should we be doing, accepting that there are some things which just cannot be done and cannot give you reliable data? So then we have anecdotes to deal with, we have impressions to deal with, and that's maybe the best we can get. We should draw a line somewhere. Thank you.
I was given the possibility of asking a couple of questions, if I may. Yes, along the lines just mentioned by my neighbor, Dr. Michael Golden, stimulation, psychosocial stimulation, is one of the components of the standard protocol of Islam treatment. No? So, what would you say was the value added of your research, aside from the unexpected finding of the detrimental or disrupting effect of having a man in the house? And regarding the study in Sierra Leone, unexpected funding you got, which is quite unusual. Would you have thought of checking the vitamin E status of the children? Because we did some studies on this in Chad to find out that 2 or 3 months after supplementation, the children were back to square one. So even if you have 6 monthly contracts, do you think it's enough?
So I start with the last question. Well, this area is, in this area there is a high rate of migration of men to Emirates. So basically what happened is that they marry girls around like 15, 16, they get pregnant and they leave to Emirates and they come back about every 2 years. So meanwhile, the wife lives with her in-laws, who are usually the one taking any decision regarding regarding her and her children. Even the fact that she can bring the child to the health centers or she cannot bring the child to the health centers. So she basically doesn't have much power. It seems that when the father is here, why the mental health status of those women or even the self-esteem decrease, it's probably related to the level of domestic violence. When, of course, we ask the question, there is 0% of domestic violence in those families. Why we check on the dad's presence is we know that the dad's opinions is very important for any decision regarding his wife, and also regarding the place of the wife in the family. So we can also say that they are already very vulnerable, but it looks like for those families, she's less vulnerable when her husband is not there. And it's not about protection, there is something else. So that is related to also to the depression. There is probably more factors that we haven't analyzed yet. That was your question about the presence of the dad and the depression. The mother that we see, they've got a child who is sick. They usually had to fight to bring the child to the OTP center to seek for healthcare. They usually saw the traditional doctor before coming. So when they arrive at the OTP, their status is already critical. Regarding the stimulation protocol, it's been included in the WHO and UNICEF protocol for years now, but what we see on the field is that it's very rarely applied. While there are now some protocols being developed, especially in Bangladesh, where they also tested for scanning up, and we see that with minimum stimulation of the children, we can see very good results. We also see good results because, again, in this kind of environment, and especially with some children, there is at some point no stimulation of the child. The mother stopped looking at her child, she stopped touching the child, she stopped having any relation with the child that would stimulate a baby normally. So we usually have very good results with even low intensity stimulation because we start with no stimulation at all. That's one point. Then also what we try to see is which kind of stimulation is the most appropriate for the mother, the children, and the most appropriate culturally. We assess in that dimension of the child development, there are 5 domains: the problem solving, the communication, it's too long. 5 domains, and only 2 are very significant. So we need to analyze more and see really what we targeted the most. But one of the interesting results is that we see the testing itself had positive effect on the child development, because at some point, I did not show it now, but we see for the family care indicators, meaning the level of stimulation at home, it really changed at 5 months for all the groups. And at 5 months, nothing happened. There were no interventions anymore. So we assume that the fact that the tester is going to the home and is testing the child for development, cognitive, communication, all domains of development, then gives some incentive to the mother to also, she understands that she can stimulate her child and her child can learn even from playing. So there is something there with the testing as well.
We'll give Oleg 30 seconds to answer 5 questions.
I think I'll just, Jeremy, I know that you guys, are interested in older people surveys as well. We need to do them more, in those settings, and need to promote them because basically the methodology is the same. If you use the same exact smart sampling methodology, you just select older people instead of children. The question here is that I will send you the results, because I cannot explain all the findings. The most striking finding was very catastrophically high levels of mental distress, because we were using standard Kessler-6 scale that is commonly used in Australia, in the US, in Europe, and we got the prevalence of severe psychological distress 5-6 times higher than you get the prevalence in the Western countries. So also it was the highest, obviously, in disabled. And this is we said that if you cannot provide psychological services to everyone, that at least disability is the first obvious screener for psychological distress in these situations, because like 70-80% of disabled psychologically distressed. Obviously there was no wasting, there was high levels of overweight and obesity in these countries. And we got very useful data on the prevalence of chronic diseases. Obviously this data was not nationally representative, but I am almost sure that if you go to any other region of Ukraine, because a chronic disease does not develop over time, overnight, after the emergency. So whatever you see probably was almost the same as the emergency. And your question, when do you say enough in this current findings of the survey? One, always when we teach, I say there are two types of bias that you have to worry about. One is measurement and one is selection. Measurement, I think we have ways to look at the measurement bias. And the earlier you can start looking at the measurement bias in the first day of the survey, the more likely you can catch the problems early and salvage something. Because if you only see this bias at the end of the survey, if you see that you had 6 survey teams and 90% of your deaths when you do mortality come from the 2 teams, and 10% of the deaths come from the other 4 teams, you basically have to throw the survey out, because it's very difficult to defend the data, right? So the earlier you catch these things in anthropometry, in mortality, in any other questions, in any other scales, it's just how diligently you try to control the quality, because we see that in many sections, with IOCF, with food security, there is no routine habit to control the quality, to even report the quality, to even look at the quality, to look at the differences by team, to report the design effect, etc., etc. So we need to do more quality checks in other sectors like we do in anthropometry and mortality more. And we really need to talk to other to colleagues, to preach this more, and hopefully we'll get through. With selection bias, even if you have to exclude some part of the population, you can still explain what the likely bias was and what your sample would likely be representative of. And even, for example, if part of your district is not accessible, then you can say, okay, this is the part that I could access, and this is the part that I could not access, sorry. What we know from other data, they are so similar, or they are different, whatever, and you can speculate a little bit, whether you can extrapolate. For example, the biases when selecting these IOCF women with young children from the phone lists, which came from Red Cross and from ICRC and from other humanitarian agencies. One, we were worried, okay, you cannot really ask about access to humanitarian aid because you're pre-selecting women who are accessing humanitarian aid. Second, are we selecting more dynamic, more thinking, more advanced women who actually went and found this humanitarian aid, and not the women who are less literate, less mobile, you could not finding? Or are we excluding, on the other hand, the most affluent, the most wealthy, the most educated part, because they already have money and they have no business registering and standing in line for humanitarian aid, right? So, but in the end, we should not exaggerate how our biases will affect the indicator of interest. Because, kind of, for example, wasting is not necessarily so different in all these kind of groups. It's not like all the wealthy people will have running water, in the house, and all the poor people will be drinking from the lake. Here, the differences in wasting and stunting in anemia are much more subtle between the wealth quantiles, etc. So I think with sampling bias, as long as we are diligent and we are trying to do our best and find these new creative ways to sample, I think we can defend, if not least explain what we have done.